Good morning. I'm going to talk about pulse-void residual volume. Is it due to bladder outlet obstruction or to Detrusor underactivity? I don't have anything to disclose, and so pulse-void residual volume is frequently in men the consequence of lower urinary tract dysfunction caused by mostly benign prostatic obstruction and Detrusor underactivity. But the correlations between PVR and the obstruction, the bladder outlet obstruction, and the Detrusor underactivity are not well defined or clear. And so the aim of this retrospective study was to investigate these relations and to assess and try to assess if the PVR is more associated with the bladder outlet obstruction or the Detrusor underactivity. So for this study, we used the data from urodynamic studies of 407 male patients with LUTs. And from the voiding phase, we calculated the BCI, the bladder contractility index, in order to explore the relation between PVR and the Detrusor underactivity, and the bladder outlet obstruction index to investigate the relation between the obstruction and the PVR. Basing on that, we divided our patient. We were able to divide them in urodynamic categories, which are this one. We had 26% of patients voiding normally, and then 35% with signs of obstruction, and 31% with signs of Detrusor underactivity, and a small percentages with both. Our statistical analysis showed that a positive correlation exists both between a bladder contractility index below 100 and the PVR, and the bladder outlet obstruction index above 40 and the PVR volume, and are both statistically significant. Further analysis showed, though, that the bladder contractility index seemed to have a bigger impact on the PVR in comparison to the boy. And so we try to define a cutoff value for the PVR that was able to differentiate patient with normal voiding from pathological findings. This is the ROC curve, and actually, remarkably, we find that a value of 100 milliliters was quite good for doing that, for doing this distinction. In fact, these are our results. In the group with a PVR under 100, the patient has one possibility out of 3 of voiding normally or showing abnormal findings. But in the group with the PVR above 100, this chance, we had only 13% of the patients voiding normally, which was a significant finding. And whilst for the Detrusor underactivity, it jumped from 35% to 52% in the group with significant PVR. No significant differences were found for the presence of bladder outlet obstruction in the two groups. So, to conclude, we can say that the Detrusor underactivity has a bigger impact on the PVR than the bladder outlet obstruction. And the threshold value of 100 milliliter for PVR is a good value to differentiate patients voiding normally and the ones showing the Detrusor underactivity. And in this group of patients, a complete urodynamic evaluation could be actually useful whenever to confirm or rule out the presence of the Detrusor underactivity is considered relevant. So, thank you for your attention.
We're open for questions. I congratulate you. I think this is an important study and an important concept. So the one thing that's missing from the Detrusor contractility index is Detrusor contraction duration.
Yeah.
So if a Detrusor contracted long enough, everyone would empty. So regardless of assuming that assumes that there's an active mechanism that opens the urethra, but once the urethra is open, no matter how weak the flow, if the bladder continued to contract, it would empty. The fact is, it loses its energy to do so. But for decades, clinicians that also do urodynamics have recognized that in every instance, whenever there's residual urine, it meant that there was something wrong with the detrusor. Either
Yes.
it didn't contract strongly enough or long enough. And again, I think this is a very important concept to understand. The converse, of course, is that you can have very severe obstruction and empty your bladder completely. So there are people that say, well, there's no residual urine, therefore the patient isn't obstructed, therefore we don't offer him treatment to ablate the prostate in men or treat grade 3 or 4 prolapse in women. And I think that's a misconception. Andrew?
Thank you.
Thank you. Andrew Gemi from Bristol. These are results, the residuals from men who are voiding during intubated flow. The catheter is in place, yes?
No, not really. Claudia.
But they are urodynamic.
The PVR was done after the uroflowmetry, before the pressure study.
Otherwise, I thought the results would be even better, but no, they're
no, that's
So they're urodynamically diagnosed, but the PVR is without the catheter.
Exactly.
Okay,
yes.
thank you.
Did I read it wrong? I thought maybe it was another paper that did both. Yes. Sorry.
Congratulations for Rubilotta from Italy. Congratulations for the study, because we know that we have to find some pathological threshold of PVR, and we don't have now this. Right. I'm presenting ICS a couple of years ago in Florence, studying the difference where that I investigate the post-void residual as a ratio of the bladder volume. And I plotted them as with the shuffle nomograms and for the Detrusor underactivity. But I found that the patient had, in my study, 20% of post-void residual urine ratio when had Detrusor underactivity or obstruction, and 40% in median when had the both condition. So I will ask you how in your study the obstruction impact so poorly.
The obstruction impact on?
So not that much.
Not that much.
I mean, it has an impact for sure, but it's like not that much. Yes.
There is a correlation with both, with obstruction and with underactivity. Our statistician was able to find that the correlation was higher with the underactivity, with BCI, let's say, than with BOE.
I mean,
probably according to the data we presented, we had a small group of patients with both conditions. So maybe this is also the cause for not having this kind of difference.
So. Thank you all for your comments and your questions and your attention. Thank you.